Okay, Assalamualaikum. Sekali lagi, good morning to everyone. So, uh, so allow me to speak in English lah, even though broken kan. But bear with me. Since this is the first formal lecture on survival analysis, so the first thing that we go through is the note, the notes on theory of survival analysis. Okay. Right. So in this note, which actually I have sent to Ikhwan, hopefully Ikhwan has distributed the notes to all of you. I divided the notes into first the introduction, and then some motivations of why we do survival analysis, and what would be the goals of model building. The goals are basically the same lah for doctoral public health candidates, especially for multivariable analysis. That is to make sure you are comfortable with running multi-variable analysis. That's number one. Which means that you should be also comfortable with in the interpretation and running of interaction. Also, in addition to that, is the ability to critically appraise a variable or many variables, whether they should be included in the model or should be excluded from the model. So what we call as confounders. The principle is that if there is a confounder, the confounder must be included in the model. That is the principle. Okay. If there is a confounder, you must include confounder in the model. But what is a confounder? That is not discussed in statistics. Okay. So that is something that is beyond. I won't say beyond, because some statisticians talk about this, but it is discussed more outside of statistics, in my opinion. Okay, for example, by epidemiologists, by social scientists. So what is a confounder? What is a mediator? What is a moderator? Okay, so we did discuss that in the public health epidemiology course. Okay, but for statistics, we won't go into like confounder is something. We won't go there. Okay, but we appreciate that if there is a confounder, a potential confounder, the confounder must be in the covariates. Okay, and then what is the difference between confounder and a mediator? Okay, because statistically they are all the same, but how would you differentiate between the two, and how would you decide whether to include or to exclude this third variable, confounder or mediator, into your model? So that's the goal of the model building. Okay. So and then we go to survival models. We look at survival data. What is the usual format of a data that suits survival analysis? What would be the outcome of survival data? What is sensor? What is censoring? How we perform analysis of survival data? And then we go to survival function, hazard function, and hazard rate. How do we compare survival between groups? For example, male and female, smoker and non-smoker. What would be the, is there any survival difference between the two groups? So when we go there, we will talk about Kaplan-Meier survival curve. Okay, Kaplan-Meier survival curve, a very classic analysis of survival data. And then we look at when we have the Kaplan-Meier survival curve, then we want to compare whether the survival curves between male and female are similar, are different or not, between smokers and non-smokers are different or not. So then we go to the next one, which is the log rank test. Okay. But there is a major problem in Kaplan-Meier is that it is very difficult, very complicated, or maybe impossible to do multivariable analysis. So because of that, we go to a relatively newer model by by British statisticians, Professor Cox, and so we are going to learn about the Cox proportional hazard model. Okay, a Cox proportional hazard regression, and then so we look at what we mean by hazard ratio, model inference, and test of proportionality, and then some references. So it is again, when it comes to the principle of statistical modeling, we as modelers, number one, we would like to estimate, okay, estimate. And second, to infer, okay, make inference, looking at the p-value and looking at the 95% confidence interval. And thirdly, we would like to predict, okay, prediction. In this case, we would like to predict the survival probability. Okay. So in the survival analysis in introduction, so so you can read this, but at the end of the lecture, this is a general objective of the multivariable analysis. That is for you to understand the concepts of multivariable statistical analysis. And then we would like you to be able to describe the approaches for multivariable statistical analysis, to analyze and interpret survival analysis, not linear regression. Okay, not linear regression. So so I need to okay, change this. Survival. Right, and then be able to appraise the common multivariable analysis in medical public literatures. Okay. Specifically, you have to know about model building process, which is going to be different and unique between each one of you. Okay, so model building process is it's not going to be the same. It's going to be different from one another. Okay, what are the roles of variables in the context of being a confounder, mediator, or effect modifier? Model checking and assessment, and then a remedial process and steps to make prediction. Right. So this is the motivations. The main motivations of survival analysis is that if you do a cohort study, a cohort study, whether it is a retrospective or prospective study, then you have an element of follow-up, right? You have an element of follow-up. So and then you have time to event. How long things will take before something will happen. Okay, so because of that, one specific analysis for that is called as a survival analysis. So you can read more here. Right, again, the goals of the model building, number one is to find the best fitting model. Okay, to find the best fitting model. Number two is develop the most parsimonious model. Number three is to develop a biologically sound model. Okay, so your model, maybe should contain these characteristics. It is fit. It is parsimonious, and then it is biologically sound. Okay, so if you have a model which is fit, but doesn't make sense, too complicated, it's not going to be useful. So if the model might be might be less fit compared to another model, but it is more sound, it is more simpler, then you might want to choose the other model, alright? Or okay. So in survival data, you have the same data, okay? You have the same data, which is rows and columns of observations and variables, okay? But in survival analysis, usually or most of the time, patients or participants have different follow-up times. Okay, different follow-up times. Okay. And then if we look at the data, usually we have or the survival data will have one outcome variable. Sometimes they call this as a status variable or the event variable. And then or the outcome of the conditions. For example, you can put as death or dead or alive. Okay. So you might have a data like this. Okay, you have rows that belongs to patients, and then you have variables, sex, race, date of admissions, date of discharge, and then this is the event or the status or the outcome variable. Okay, for example, this the first patient is a female patient from Malay race, admitted on the 31st of October and discharged on the 2nd of November. And sensor, it means that the outcome here is dead or alive. So sensor is alive, it's alive. It means it is not dead. Okay, it is not dead. So so how many days here? To 31st, one, two, one. So like 2 days. 2 days of admission, and then she was discharged alive. Second patient, a male from Malay race, admitted on 23rd of May and discharged on the 6th of June, but discharged as dead. Okay, discharged as dead. So this is the event, dead, dead, dead. So all these are the event cases, and then those who were discharged alive, or maybe they just ran away from the ward, missing in action, abscond. So that will also be considered as censored. Anything that is not the event which is dead will consider as censored, because we don't know what will happen to that person. For example, if this male Malay admitted on 28th of June and discharged on 6th of July and censored, it means that this patient was not dead, but maybe when he came back to his house after 1 day or after 2 days, then he might have died. So because of that, because we don't know the real status of the censored patients, so that's why we call them as censored. Okay, censored. Right. So the outcome can be, many things. So there are two types of, not two types, there are two variables usually for survival analysis. The number one is the outcome variable of interest, okay, which is time until an event to occur. For example, if you just now, how many days the patients took from admission until death or until discharge, okay, how many days, or how many months before someone will have relapse of certain disease. So how long does it take, okay, and the event of interest is relapse. Okay, there are two things, okay, one is the time, and two is the event that occur, okay. Censoring is anything that is not the event. If the event is death, for example, just now, death that took place while in admission. So if the patients run away from the hospital, or if the patients died because of, some other disease, not because of the disease of interest, then he or she will consider as censor, okay. So there are right censored and there are left censored. So the right censor is this one is, for example, for patient number one, he was admitted here. Then after 3 days, for example, he died. Okay, so event is date 1. And then a second patient was admitted, let's say almost the same time, and then 5 days later died. So there'll be 5 days here, and then event is died. 3 days here, and then event is died. And then this guy, let's say 10 days, and then after that, event, he's died. Okay, he's dead. Okay. For this guy, he was admitted almost the same time, but let's say we do a study for 2 weeks. Okay, for 2 weeks, 14 days. And after 14 days, we say, okay, that's it. We are going to close the study, stop the study. And then so whoever that were alive at this point of time, at the end of the study, will consider as right censor. For example, this guy, 14 days already, and then he's like, okay, that's the end. We told him, okay, Encik study dah habis dah. Okay, so tak apalah, boleh balik, for example. Okay, so the status of this guy is censored, and then how many days? 14 days. Okay. And then let's say this guy, he stayed in the work for 5 days. And suddenly, the nurse came to the ward the next day, and then he's no longer there. So, the nurse said, "Doctor, the patient is not there anymore. Maybe he has run away, abscond. But when I saw him yesterday, he was still alive, lah. So the last day we saw him, which 5 days of admission, he was still alive before he absconded. So we put this as censored also. Okay, the left censored is something that is a little bit more complicated because we don't know what happened to them before this, all right? So you can read about left censored. Usually we can't do much about the left censored because we don't know the real status, but we know something about the right censor. So censoring is always a problem in the survival analysis. Okay, you instead of doing survival analysis, you can do, for example, case control study. Like you take those who are alive and those who are dead, and then you analyze, right? You can do that. You can do that using logistic regression, but you don't have time to event and you don't have censoring. So these two information actually can provide you more information about the conditions in comparison to logistic regression. Okay, so you have time and you have event. So these two, you don't have it when you do logistic regression. So if you have this, if you have time to event and also the event, you got more information, so you can do better models. Ada soalan ke?
Nak tanya,
Yep.
yang dark blue ni adalah
Yes.
light censored, yang dark blue error ke salah
This one,
satu ni?
Yeah,
Sebab
this,
kalau tengok
both of them ni right sensor lah.
left censored ni yang light blue ni lah.
This one. Light blue is the left sensor.
Tapi kenapa macam
This, for example,
apa beza dia? Kenapa cuma dia punya starting measure dia for left censored ni, dia punya starting dia lebih unknown lah. Itu beza dia antara dengan light censored ni kan.
right sensor, we know the status at the beginning. For left sensor, this is a study. For example, if you do study on AIDS lah, this is a typical example of left sensor. You do study about AIDS kan. You want to know how long does patients take from HIV to AIDS. Okay. So you know that some tests tu dia tak berapa bagus. So it can detect the duration here. The duration from getting HIV to AIDS, for example, let's say this is 5 months, okay? 5 months. But maybe before this, he's already got evidence of AIDS, but were not detected by the test. So maybe the real time from getting HIV to AIDS was 7 months, not 5 months. So the 2 months that we miss here is because of the left sensor. Okay. So it's something that you don't know. Actually, you thought that the time taken from HIV to AIDS is 5 months, but actually dia dah ada dia punya AIDS tu sebenarnya, tapi lambat detected because of some limitation in the test, for example. So because of that, that's the effect of the left sensor. Right. Similar to cancer lah. For cancer, if because how long does it take for the cancer to be maybe for metastasis, for example, right? Maybe 1 year here, but actually maybe metastasis have happened longer than that. Not 1 year, but maybe 16 months, for example. But we miss that. Because of these very tiny cells spread around. So we miss that. So that is another what we call as the left sensor. Right. It's a bit complicated. I think maybe for general, the RPH, you don't have to really differentiate between what is left sensor, what is right sensor. Just roughly lah, you know that okay, this is the problem of left sensor. This is what right sensor is. Right. But sensoring also has some assumptions. Okay. For example, I mentioned this guy again. This guy absconded from the ward, and this guy still alive at the end of the study. Okay, and this happened. Right sensor must happen randomly. Okay, they happen randomly. Okay, if patients run away from the wards because of the treatment, for example, you got 100 patients, admitted, and then for the treatment for stroke, do you do like maybe you do some kata apa, leaching apa ni, you take blood kan, cucuk blood and then draw blood for 1 liter for example, and that make patients scared and they run away from the wards for example, right? So that censored does not happen by random. So that doesn't apply here, okay? So that sensor is, you have to deal in a different method. Okay, so sensor must happen randomly. For example, people abscond from the ward happen randomly. Patients got discharged by the physician randomly. Okay, and censored also happen independently. For example, if a patient run away from the ward, and because of that, the neighbor saw him run away and thought, I need to run away also. So that sensor does not happen independently. Okay, so because of that, you can't use this assumption. So the assumptions are not met. So you have to analyze the data differently. Okay, so sensor must happen independently. Sensor must happen random, and sensor do not contribute significant information or non-informative censoring. For example, the example that I give you is if you give a drugs, if there are 100 patients being admitted for stroke, and you do some crazy intervention, taking blood 1 liter from them, and then because of that they run away. So the sensor actually have some information on that, because they run because they're scared of the intervention. Or if you do chemotherapy, for example, you have 100 patients, and then you give chemotherapy, and because it is a new chemotherapy, the patients develop severe side effects, and then they don't come back. They don't come back for the next visit. When they don't come back, you will consider that as sensor, right? Okay, you will consider a sensor, but that sensor actually means something, because they did not come back because they had severe side effect, for example. Okay, because of that, that kind of sensor does not meet the sensory assumptions. So data must be handled differently. All right. So and then you said, okay, all right, so we can do, logistic regression, for example, because we have yes and no, and maybe some of you will say, okay, we are interested in the time to event, right? Time to event, 5 days, 7 days, 10 days. Why don't we just do linear regression? Why don't we just do linear regression? Because linear regression is also, can analyze numerical data, and time to event, 5 days, 10 days, 14 days, 16 days are basically numbers, right? So can we do multiple linear regression? Okay, if you do that, it is not error. The software will still give you results, but the problem is that linear regression has got their own assumptions, right? LINE, and the assumptions are usually or are always violated. Okay, non-normality, etc., etc., and because of that, multiple linear regression is not an analysis of choice for survival data. So when we analyze survival data, we want to estimate and interpret survival and or hazard function. Okay, there is a new term here: survivor and hazard functions. Okay, and then we want to compare the survivor and hazard functions, and we want to assess the relationships of explanatory variable to survival time. Okay, so these are the goals of survival analysis. And because of that, we have survival functions. We have to estimate survival functions. We have to estimate hazard function. So this are some of the maths of survival analysis. This is survival function, which is the probability of a patient, of someone to be alive beyond certain time. Okay, so the probability, the cumulative probability is 1. So if you minus the probability of fail, the probability of death, for example, then you get probability of survival. So basically, if you know survival function, then you can also know survival or the hazard function. So, if you know one, you can know the other one. The most common estimator for survival function is Kaplan-Meier estimator, also known as the product limit estimator. Okay, Kaplan-Meier. Okay, Kaplan-Meier estimator or product limit estimator. This is an old classic method to estimate and compare survival function. Okay, the Kaplan-Meier or the product limit estimates. The other estimators include Nelson-Allen estimator. Okay, so but Kaplan-Meier is what we call is more commonly used compared to Nelson-Allen, but both will provide you the survival function, and because of that, you can estimate the survival probability. You are not going to estimate the survival time. Okay, remember, you are not going to estimate the survival time. You are going to estimate survival probability. Okay, survival probability. Right. So this is an example of Kaplan-Meier estimate. Okay, Kaplan-Meier estimate, where you have on this y-axis the survival probability from 0 to 100, from 0 to 1, and on the x-axis you have the duration or the time. Okay, so over time you see the probability of survival. For example, in this case, the event is maybe, I think, dead versus alive. So you see the survival of the probability of surviving reduces over time between the two genes. Okay. So what you have here is time and the event. Okay. Right. Try have a read about hazard function and hazard rate. So so this is an old estimator. Okay, an old estimator, Kaplan-Meier, very classical analysis, and then after some time, statistician Sir David Cox, British statistician, have developed a more advanced estimation method for survival analysis known as the Cox proportional hazard regression. So this is something much later lah, compared to Kaplan-Meier. So it means that if you don't want to do Kaplan-Meier, it's okay. You can just go straight and do Cox proportional hazard regression. Okay, but so this is actually much better than Kaplan-Meier. Okay. Again, you have on the x-axis the time, and on the y-axis is the survival probability. Okay, but in this case, it is a bit of change in the axis. This is, instead of survival, you have hazard. Okay, hazard of the probability of hazard. Okay, probability of hazard. You are comparing, in this case, low altitude and high altitude, and the obesity diagnosis, which is, I don't know, quite strange, kan? So, so if you compare survival estimates, for example, if you want to compare, okay, the survival probability between gene A and gene B, of course, it is obvious here, right? You would say that, oh, actually, patients with gene B signature have lower survival probability compared to patients with gene A signature. Is this obvious here, right? But in the event which is not obvious, then you might want to do a formal test comparing the survival estimates. So how to do that? Number one, show the graph. Okay, show the graph to display data in each group. Okay, like this one lah. Okay, like this one. Show the graph, the Kaplan-Meier estimates. Number two, split the graph into each group. Yes, like we did just now lah. Okay, so you can have the overall group, and then you can split into gene A and gene B because this is your main interest. And after that, you can compare the survival estimate. Okay, you can compare the survival estimate. How to compare? You can compare using the log rank test, the Wilkinson test, the Taron-Ware test, the Peto-Prentice test, the Flemington-Harrington test. So there are at least five lah. Okay, at least five. There are many more actually. But there are at least five. Each one use different weights in the case of ties. But in your case, I don't think you have to know in details about the weights. Just know that there are multiple tests to do survival probability comparison. Number one, log-rank. Number two, Wilkinson. Number three, Taron-Ware. Number four, Peto-Prentice. Number five, Flemington-Harrington. If you use Stata, then Stata has a little bit more options compared to R. R, I think, has got these five things lah. So this is examples of log-rank test. So we compare the this is a specific survival between low PI4Ka and high PI4Ka. So we can see there is obviously a difference in terms of survival probability between patients with low PI4Ka and high PI4Ka. Patients with high PI4Ka have lower survival probability compared to those with low PI, okay? And also in the recurrence-free survival group. So, and this is the p-value from the log rank test, okay? So that confirm the survival probability between the two groups are different. What else? Kaplan-Meier survival curve. This one lah. Okay, this is these are the Kaplan-Meier survival curves, right? And log rank test. This is the formula for the log rank test, which you don't have to memorize. If you memorize, will you get extra marks? Not sure. Okay, but basically the log rank test is a chi-square test. We just compare between the observed and the expected value and the variance of the two. So quite easy to do. Quite easy to do. It's not something very complicated. And after that, after a few decades after the Kaplan-Meier survival curve was developed, then a statistician, David Cox, developed a new methodology to analyze survival data, and he called it as Cox proportional hazard regression. Okay, Cox proportional hazard regression. So the formula for the Cox proportional hazard regression is that the hazard of an event for a given time equal the baseline hazard, okay, baseline hazard, which is this one, and then times the exponentiations of the linear combinations of b1 x1 plus b2 x2 plus b3 x3, so on and so forth. We did this, okay, we did this um, during our logistic regression and linear regression. We know that the linear combination, the beta 0 plus beta 1 x1 plus beta 2 x2 plus beta 3 x3. So that is the linear combinations. So the difference is that here we don't have beta 0. Okay, we don't have beta 0. We have what we call as the baseline hazard rate. Okay, baseline hazard rate, which is the hazard at time 0. Okay, this one. Then we times with the exponentiation of the linear combinations. So the good thing about this formula is that if we compare between two groups of, for example, smokers versus non-smokers, if we divide this, okay, we have a division here. We can cancel out the hash O, okay, the baseline hazard. Can cancel out the two. And then what that leaves us with exponentiations of the linear combinations. And from there, we can calculate the hazard ratio, okay, hazard ratio or hazard rate. So we don't have to specify the baseline hazard rate. We don't have to specify that. And because of that, this methodology or this approach is known as the semi-parametric models. Okay, so Cox proportional hazard regression is the semi-parametric model. Okay, so the hazard at time 0 is the baseline hazard. Okay, and this exponentiation is the exponentiations of the linear predictor of the linear combinations. All right, so kejap nak bawa. Okay. So so for example, if we compare, where's the mouse? Okay, if you compare death rate after cancer between men and women, or between age 50 and age 20. So we can have one here, the hazard for male and the hazard for female. Then we divide the two, we cancel the baseline hazard. Cancel, and that will leave us with exponentiations of linear predictors. And from there, you can calculate the hazard rate, okay, or hazard ratio. So you just exponentiate the beta value, okay, exponentiate 1.29, so we got 3.65. So we know that for example, women or men will have 3.65 times the hazard to develop cancer, for example. Right. So this is the estimation. Okay, when we come to model inference, of course, we will look at the Z statistics, also known as the Watt statistics, and the likelihood ratio of the LR test. Okay, and then there is public health proportional hazard assumptions. For proportional hazard assumptions, we can use graphical plots or goodness of fit tests. Okay, for graphical plots, we will draw the log plots or the observed versus expected plot. Right. Tak apa, jangan pening tak apa, slowly. And then for test of proportionality, remember the Cox proportional hazard model? There's a word there, right? Proportional. It means that the risk here should be proportional, This is proportional to this one. This is proportional to this one. If this one cross like that, so it is no longer proportional. And because of that, Cox model is not appropriate. But if it is like this, which is proportional, then you still can use Cox proportional hazard regression. Right. But you have to test it. Okay, you have to test it. You can use a couple of my survival curve, just like we show you just now. Or you can you can make a plot, but put time dependent covariates in the Cox model, and then you can you can make plots based on Schoenfeld or residual. All right. So don't worry. We still have time to cover this. We got 2 weeks, this week and next week, to familiarize ourselves with survival analysis. So so don't worry. Okay. So this is the note for the survival analysis. So again, what I've talked about is about survival analysis is, number one, I mentioned about the goals of model building, and then we talk about the survival data, how your data should look like, what is censoring, and what are the characteristics of the sensor variable, independent, random, and doesn't carry significant information. Then we talk about Kaplan-Meier survival curve and how to compare the two using log-rank test, Pito, Taranware, or Flemington, Harrington, something. And then we also learned that a newer methods to do survival analysis is to use Cox proportional hazard regression. Okay, Cox proportional hazard regression, because Cox proportional hazard regression can handle multivariable model. Kaplan-Meier cannot. Okay, you just, it is like a univariate or univariable analysis. You can't do multi-variable survival analysis model. So this is an old method. If you do Cox, you don't have to do Kaplan-Meier, okay, because it is redundant. Okay, this is more powerful. Okay, but yes, we learn about Kaplan-Meier because many statisticians or many modelers are still familiar with Kaplan-Meier, so we learn about this. And then we use a log-rank to compare survival curve. Okay, what we are comparing is not survival time. It's not survival time, remember, but we are comparing survival probability. Okay, survival probability. And we also learned that the newer method is called as the Cox proportional hazard regression model. This is a semi-parametric model because we don't have to estimate the baseline hazard. Okay, we don't have to estimate the baseline hazard. We learned that from the Cox proportional hazard regression, we can estimate the hazard ratio. How to do this? Just exponentiate the beta value, just like the odds ratio. Okay, but here, when we exponentiate, we don't call odds ratio, but we call as hazard ratio. Hazard ratio. And then from the hazard ratio, we can look at the p-value and the 95% confidence interval of the hazard ratio, 95% confidence interval of the hazard ratio. Okay, remember one thing. In linear regression, we estimate the beta. In logistic regression, we estimate the beta. In the Cox proportional hazard regression, we also estimate the beta. Okay, but in linear regression, the beta is just the beta or the average change of y. But in the logistic regression, the beta is the log odds. Okay, the log odds. While in the Cox proportional hazard regression, the beta is the log hazard. Okay, log hazard. Odds ratio, log odds. Cox proportional hazard is log hazard. If you exponentiate the log odds, you get odds. If you exponentiate log hazard, you get hazard. If you exponentiate the beta in log odds, in the logistic regression, you got odds ratio. If you exponentiate the beta in the Cox proportional hazard, you get the hazard ratio. But they are all the same. That's why I've told you that the statisticians, when it comes to this modeling, is about estimation of the beta value, making inference by looking at the p-value and the 95% confidence interval, and making prediction to make prediction. In linear regression, we predict the average y value. In the logistic regression, we predict the log odds, the odds and the probability. And in the Cox regression, we predict the log hazard and the survival probability, even though it is a little bit complicated here when it comes to prediction of survival probability. Okay, but don't worry about that. So I guess that's all untuk notes before we take a 15 minutes break, and then we go to the practical. So any question? Ke semua dah tidur?
Tak ada.
Ada kok. Ada.
Go dengan digest benda baru, Prof.
Digest benda baru, okay. Yeah, it's actually something baru in terms of topics lah, tapi the steps are the same. I won't say the same lah, the overall workflow to is almost the same. Is that you have the data, then think about the goals of the analysis, and then do the estimations, and then do the inference, and then do the prediction, and then what else? Then check the assumptions, right?
Prof.
Yeah.
So, Prof nak tanya yang kaitan dengan censoring tu. Sensor data tu mana dia kira macam incomplete data lah kan. So, adakah dia consider missing data ketika remove ataupun still masuk kan?
Okay. Okay, cuba mute sekejap. Okay. Sensor is not a missing data. Okay, sensor is not a missing data. Sensor is sensor is an event yang a status that is not the event. For example, kalau if your interest is, okay, let's say if the event, if the interest is death, so if you observe in a cohort of patients, this patient died, okay, that's event. This patient died, that's event. This patient died, that's event. And suddenly there's one patient suddenly abscond from the study, okay, abscond, run away from the study. You consider this as censored because the last time you saw him, he was still alive, okay. And then another patient got hit by a car, involved in a road traffic accident, died. And he died, but because by definition, say the death must be death directly from the conditions of cancer, for example, then you will also consider these patients as censored. Censored when? Censored on the date of death, his death, because his death actually from road traffic accident, not from cancer. Okay. So, but it is not missing data. Okay, missing data is like this. Okay, missing data is maybe in how missing data? Missing data is like you missing data is happen for the covariate. For example, the age, the sex, the total white cell count, HB count. That one is missing. That the covariates are missing. For example, some patients too don't have a full blood count results. Some patients doesn't have. Some patients don't have the chest X-ray results. Some patients don't have the weight, the height, for example. Like that. So that are the missing data. Missing data happen for the covariates and rarely on the outcome. Okay.
Oh.
Yep.
Yang tadi Puan cakap kalau comparison of the survival kita using Kaplan-Meier method, which is Kaplan-Meier itu is the old school estimator lah. Dan kalau kita guna Cox proportional hazard regression tu, maksudnya kita skip lah dia punya step of comparison survival tu.
Macam mana Ikhwan? Dia lain sikit.
Macam Prof cakap tu, yang comparison of survival tu kita using Kaplan-Meier method based on graphical, test semua tu kan. Tapi kalau kita buat yang Cox proportional hazard regression tu, maksudnya kita still kena buat comparison juga ke? Dah tak perlu.
Kaplan-Meier is method yang lebih klasik kan. Lepas tu statistician develop Cox proportional hazard regression. Semua benda yang Kaplan-Meier buat boleh dibuat oleh Cox. Okay, for example, semua benda yang semua benda yang Kaplan-Meier boleh buat boleh dibuat oleh Cox, tapi tak semua benda yang Cox boleh buat boleh dibuat oleh Kaplan-Meier. So that's why Cox is a more powerful method. How powerful or how flexible? In Kaplan-Meier we can create a survival probability. Cox also can create survival probability. Kaplan-Meier we can compare survival probability between groups using log rank, Taron-Ware, Pito-Pito. Cox can also do survival probability comparison using Ward test, using likelihood ratio test. Okay, what else? Kaplan-Meier cannot do multi-variable analysis. It means that kita tak boleh plot survival curve based on multi-variable model, but Cox proportional hazard regression can, we can use as data from Cox proportional hazard regression to plot the survival or adjusted survival probability based on the multivariable model.
So basically, what option is suggested, and then they can do more compared to the whole method.
Yeah. Cumanya still banyak lagi paper yang masukkan Kaplan-Meier, not sure why, but not sure why, tapi it's like redundant lah if you do Kaplan-Meier and after that you masih lagi buat Cox proportional hazard regression. So okay, don't worry, kita stop for 15 minutes. Pukul 11 kita start balik and kita start with practical. Is that alright?
Alright, bro.
Sempat lagi buat air ke? Okay, Assalamualaikum.
Salam.